Academy of Family Physicians and the staffer for the Academy's Health Equity and work group, as well as the Health Equity member interest group. So we're so glad that you're here today. And we will be with you in just a second as we pull up our show for this afternoon. Let me try that one more time. Okay, Desma, I need a thumbs up. Are you seeing the slideshow? Okay, all right, we'll get this started. We'll wait a minute or two. I guess I've already used up one of the 2 minutes. Well, everyone, I just wanted to thank you. 31 and a half years ago, I started, just a minute. Desma, are you recording? Okay, great. 31 and a half years ago, I started at the Illinois Academy of Family Physicians, and my first job was to work with residents and students, and I'm coming to the end. I'm retiring at the end of the year. And so this is actually my last big show, and I'm just so thrilled that it's with students. It's where I began, and so glad it's where I'm finishing up, because you all are the future. Not only are you going to have to take care of me once you get through with all your training and my family, but you're the bright hope for the future. You're the ones who are going to make all the changes, you know, we had hoped to make in our lives, in our professional lives. And I'm just can't be more pleased to introduce Laura Hurley. Laura is the current student board member of the Illinois Academy of Family Physicians. And she, along with last year's student board member, Tiffany Koo, thought this up. They were waylaid by COVID-19, as many of you have been, and they participated in our health equity work group. And each of them individually sent an email saying, what can we do? So since April, they have been working on health equity issues and projects, and they thought this one up all by themselves, and we are so glad that they're here. So I'll stop chatting and turn it over to Laura Hurley.
Thank you, Vince, and I just want to echo his welcome. So good afternoon, everyone, and welcome to our IFP Student Town Hall. We are thrilled at the opportunity to gather in this virtual space to discuss these important issues with several incredible panelists that you'll meet in just a few minutes. And we're grateful for all the support that the IFP has given us to make this event possible. But before we get to the introductions of the panelists, we just want to go over a few guidelines and a brief outline of how the town hall will unfold. So first, we're asking all attendees if you could please ensure that you are muted, and also turn off your camera, at least for the first half while the panelists give their presentation. While they're presenting, please use the chat feature to submit any questions, as we will have a dedicated Q&A time at the end. And then panelists will just ask you to keep your camera on throughout so that as you speak, those in attendance can connect who's speaking with your face. So then on the next slide, we'll just give you a brief outline of how the town hall will unfold. We'll start with introduction of the panelists, and from there move on to our presentation. We've divided this town hall into 4 main themes. As you know, the title of the town hall is Addressing Systemic Racism and Health Equity. And we by no means are going to be able to touch on all the important issues under this large umbrella. But our goal for this town hall is to be a starting point where we can connect, share ideas, hear from people who are doing incredible work already addressing some of these topics, and perhaps from this event move forward unified as medical students across the state and across the region, and continue to have these conversations. So these are the 4 topics that the panelists will be touching on. Following their presentation, we'll have that time for Q&A before we wrap up. And then just one last comment before we do introductions. We went over the guidelines, but as many of you may know or may have experienced yourselves, we will be bringing up some topics that can be somewhat triggering for individuals. So we want to make sure that everyone is respectful and helping create this safe space that people can share questions and thoughts freely and without judgment. So without further ado, as Vince said, my name is Laura Hurley. I'm the current IFP student president and representative to the board. And I will be one of the co-moderators alongside Tiffany Koo. And so I'll hand it over to Tiffany to introduce herself very briefly.
Hi everyone, thanks for being here on a Saturday afternoon on a chilly fall day. I'm a fourth year at Loyola. I was the previous IFP student president, and I'm really excited to co-moderate this panel with Laura today. Nice to meet y'all.
Great, and quickly we'll just go through some very brief introductions for our panelists. So panelists, I will read out all of your names, and once your name is called, if you would just be willing to introduce yourself, share a little bit about your medical training background, where you're currently working and practicing, and your role at that institution and or program. So to start, we'll start with Dr. Amy Blair.
Good afternoon, everyone. I'm Amy Blair. I'm a family physician in Maywood with Loyola, and I am also the Assistant Dean of Educational Affairs, one of the gobs of deans of education at Loyola. And I also direct our Center for Community and Global Health.
Wonderful. Thank you, Dr. Blair. And next, Sumbul Siddiqui.
Hello, everyone. My name is Sumbul Siddiqui, like you said. I'm a second-year medical student at Loyola. I'm also in the MD and PH program at Loyola, so in combination with the School of Parkinson Sciences and Public Health. And I'm happy to be here with y'all. Thank you again.
Wonderful. Thank you, Sumbul. Next, we have Dr. Ronald Rembert Jr.
Good afternoon, everyone. My name is Ronald Rembert Jr., and I am a family physician currently working with a company called R1. We work with hospitals all over the United States. Currently, I'm leading a team of physicians that work from Maine to Hawaii with different hospitals on compliance with Medicare guidelines, as well as providing education to those hospitals, and give lectures at various hospitals, as well as some of the medical schools as well. As a matter of fact, good to see you, Laura. Remember you from the Family Medicine Leadership Group.
Yes, thank you, Dr. Rembert. Next, we have Lloyd Seeley.
Hi, everyone. My name is Lloyd, and I'm a third-year medical student at Rosalind Franklin. I currently work with CHAMP Alumni Leadership, as well as the task force for M1, M2 curriculum, just to see, how things are going, if students have met their objectives for matriculation to medical school. Thanks for having me.
Wonderful. Thank you, Lloyd. Next, we have Dr. Steve Rothschild.
Hi, everyone. I'm Steve Rothschild. I'm the chair of family medicine at Rush University Medical Center. I'm a graduate of the University of Michigan, both undergraduate and medical school. Did my residency in family medicine at Metro Health, which is a county hospital in Cleveland, Ohio. In addition to being in practice at Rush, I also chair the Health and Medicine Policy Research Group, and I'm a member of the Chicago Board of Health.
Wonderful. Thank you, Dr. Rothschild. Next, we have Stephanie Moss.
Hello, everyone. My name is Stephanie Moss. I'm a second-year medical student at Rush, and I'm a part of Family Medicine Leadership Program. And I'm also one of the original founders of CHARGE, which is Chicago Homeless and Health Response Group for Equity, and that we'll be talking on that today.
Welcome. Thank you, Stephanie. Next, we have Dr. Santina Wheat.
Hi, I'm Tina Weed. I am the program director for the Northwestern Family Medicine Residency Program at Erie Humboldt Park. I am also an associate professor at the Northwestern Feinberg School of Medicine in the Department of Community and Family Medicine. I am a practicing family physician with obstetrics, and I went to medical and public health school at University of Illinois in Chicago, so I'm home, and then also went to residency at the program for which I'm now the program director.
Wonderful. Thank you, Dr. Wheat. And last but certainly not least, Warren McGee.
Hi, everyone. My name is Warren McGee. I'm a fourth-year student at Northwestern, the Feinberg School of Medicine. I'm also returning MD PhD student. Really excited to be applying into family medicine this fall. The two things that I do on campus that I'll be talking about today, one is I'm a member of our curriculum task force on inclusion and bias. And secondly, I help manage a student discussion group called Sustained Dialogue, where we talk about, it provides spaces for people to talk about really difficult issues. So I'll be talking about both of those today.
Great, thank you, Warren. And thank you, panelists, for introducing yourself. With that, I'm going to hand it over to Tiffany as she leads us into our presentation.
Okay, such a great panel of speakers. I'm so excited. So first, we're going to start off with Dr. Amy Blair and Symbol from Loyola, just to talk about maybe the role of medical education in just training our next generation of physicians in health equity and racism. So I'll turn it over to them.
Thank you, Tiffany. So I'm going to start off and give a little bit of a framework of how Symbol and I saw this as we met and talked it over. I actually was really inspired just before coming on this today, a podcast called Innovation Hub. A doctor was talking about how for COVID-19, we need many imperfect solutions. So for handling something so complicated, putting all of our faith in one miracle cure or miracle vaccine is probably not as effective as many imperfect solutions. And that's actually how I feel about improving health equity as well, and how I feel about medical education. So when I think about some of the solutions, I will start by saying ours at Loyola are imperfect. And I would imagine that we feel that at all of our institutions. But there are probably three buckets that we've really focused on for improving health equity within the medical education realm. And first is admissions, which I think others will talk about today as well. When we can increase the number of students being exposed to diverse lived experiences, we learn from each other. So I think it's really difficult to imagine a curriculum that can go over all of the different backgrounds, ethnicities, languages, cultural beliefs. But if you have a milieu of learners that are all able to share those with each other, I think that beats any sort of PowerPoint slide show of cultural competency. And so we've focused a lot at Loyola on DACA students, admitting DACA students, which I think has done a tremendous amount for the whole entire school's understanding of immigration status as a health factor. So that's one bucket. The second, I guess, would be the curriculum itself. So curriculum in terms of, didactic sessions, small group sessions, the design curriculum for the whole school. We have tried to incorporate social determinants of health, specifically how transportation or affordability may impact a particular outcome. We've had a little bit on implicit bias, but I will say that in general, students don't really feel they're getting enough, and they might not feel in terms of the whole class in general, some of them might not prioritize it, especially when up against the content that they know they're going to get tested on for step one. So we have that challenge. So I think the third thing we do is really where Symbol and I focused a lot, and that was community engagement. So I do really think that to teach health equity and to talk about racism, we have to also have those opportunities for students to be outside of the classroom. Feeling more vulnerable is important, right? I think any practicing physician knows that we have to be experiencing all the lessons of patient care and go through it in order to really learn it. For instance, we could have a whole lecture on health literacy and talk about the teach back method, But I think until students are really in the community, working with someone with low health literacy, feeling what that's like, they're not going to be able to gain the skills that we need to actually narrow the outcome differences between different groups. So I think of all the things that go on at Loyola, community engagement is certainly a high point. I think one of the things we struggle with is many of those opportunities are extracurricular. So, you know, where you require community involvement versus allow for opportunities for students to become involved is a really interesting discussion. I do think that students who choose their extracurricular paths in community health or in health equity really do end up having a much more intentional and genuine experience. So I think that's one of the things that we could improve on too, is finding where it's important to really include this content as a requirement for all students. So we've had amazing leaders, student leaders in the White Coats for Black Lives group, other student interest groups, and within my own group of community and global health honors students, you know, bringing the content on racism and anti-racism to the students has come in so many different ways in the last 6 months. And as well as, you know, the community engagement that we've been doing in terms of a response to COVID-19 in Maywood, Melrose Park, Berwyn, and Cicero, which are our suburban Cook County areas that were disproportionately affected. So I think, you know, this has been a moment where a lot of things have crystallized. And for my final statement, I would just say that what I've learned the most is that we should let students lead. When students lead, you bring the new ideas, energy. I really do think that faculty, particularly older, need to start to get out of the way and let students show us how to do this work and how to teach health equity in a way that's going to really be meaningful in their professional development. And then also, I think you should all be family physicians, and then you should all get to be deans and CEOs, because I think you know, we are so nimble, and we are kind of, when we see there's a fire, we are going to go put it out. And so that's a great recipe for being a leader that can actually make some change. One of those great future leaders is Sumbul Siddiqui, so I'm going to let her take over.
Thank you, Dr. Blair. So I guess just like Dr. Blair was saying, I was really thinking about this topic and, you know, how my school has allowed me to really learn about health equity and racism. And so I'm going to share some of these experiences. So starting off, so Stritch is located in an underserved community of Maywood, where there are nurses. And even before I moved here, I had already heard of all these bad stereotypes about Maywood and why I shouldn't live there and I should be fearful. And I was very disheartened because I really wanted to live close to Stritch. I didn't want to live far away from campus. So right before we start our first academic classes, we have service and we get to hear from a local professor who's been there for decades, and we learn about prosperity, its role in the Underground Railroad, to now how it's become a food desert and how it's these healthcare disparities. So we really do have the opportunity to get to know our community and learn about the organizations that exist in Maywood, such as the Maywood homeless shelters and grassroots organizations that we can be a part of. And I really do appreciate that. And it takes away those misconceptions that I had before I even moved here. And for me, I'm an active member of the Coalition for Spiritual and Public Leadership in Maywood, and I serve on their immigration committee. And so it's probably almost 2 years now that I've been consistent in volunteering outside of med school. And it's because of everything I've learned from Stritch itself that I can do this. Like Dr. Blair was saying, we have several honors programs. And I'm also in the Community Health and Global Honors Program. And I learn a lot about global and local healthcare disparities. We have to do a lot of service hours, be involved with community leaders. We attend several workshops to learn about what the real leaders do. Next week, I'm looking forward to a global health equity session on national healthcare reform. So it's all very exciting, and I just continue to learn with good faculty and real life heroes. And I guess within the student body itself, I think a lot of my colleagues really do care about social justice issues. There are a lot of student organizations, and I like to highlight that even if there's a student organization that doesn't exist within Stritch, we have the opportunity to create new ones. And like Dr. that recently, with the Black Lives Matters protest and the injustices, the students, my colleagues, they came together to sign a petition to confirm the dignity of our Black colleagues. And I'm really proud of this new student org called the White Coat to Black Lives. Right now, they're working on a webinar series where we can learn about racial injustices. We're not just students can join, but also people in the community. Honestly, I wish I had a lot more time to be part of all these great initiatives. And really during this pandemic, I think a lot of my classmates wanted to still help because we weren't allowed to go back to campus, right? But that doesn't stop us from getting creative and figuring out how to work together because of these relationships we've been building since day one. We formed the Loyola Student Rapid Response team, and out of it, I joined the Health Justice Initiative, and we co-organized the COVID Equity Response Collaborative at Loyola, known as Circle. There is a slide, I think, yes, right there. I see it on my phone now, where we knew that communities like Maywood would be hit the hardest, and found out that there weren't any testing facilities nearby. Community members, we learned about their challenges. Didn't get tested either because it was too far away, they didn't have cars. At first, we tried to actually contact the Walgreens in the community and see if they could become testing facilities, and we didn't get a response. And so finally, we decided that maybe we can try and set up something. And we were able to set up the free COVID-19 pop-up testing sites in Maywood and Melrose Park. We've tested over 600 community individuals. It took a lot of work to put this together, and I'm proud to say that our work is going to continue through the grant funding. But again, all of this is possible because of the Stritch faculty, the interdisciplinary teams that we have, the relationships we've already built, and that Stritch has allowed us to grow and do. And I think we really do learn from each other. But this is because, again, we have that supportive learning environment and opportunities to volunteer. Most of our curriculum, though, is focused on step studying and passing boards. So I think we do learn about not enough on how to be anti-racist. Appreciate classes like patient-centered medicine that teach me to be an empath. But most of the time, I'm learning about diseases. So unless I'm forced to really study for a particular topic, I get a lot of my knowledge on healthcare equity and racial disparities through volunteering, through the honors program that I'm in, and through the extracurricular activities that I'm a part of. But these have been my experiences. I'm just a second-year medical student right now, and I'm sure Stritch has a lot more to offer. So thank you again, everyone, for listening and joining us today.
Thank you, Dr. Blair and Symbol. I actually worked a lot with both of them on Circle, and I want to say that Symbol was a trooper and meeting with like community organizations on the ground to like get everything set up, and Dr. Blair was amazing and just being like very flexible and organic with the whole process. So I can totally vouch for like a student-led process. Next we have Dr. Rembert and Lloyd from CMS. They'll be talking about advocacy. And I want to acknowledge that advocacy is like a very broad umbrella, and we'd be happy to learn more about like anything on this national, state, or even like an institutional level. So I'll turn it over to them.
Awesome. Thank you. We appreciate this opportunity to share on this platform. First, I'd like to tell Vincent Keenan, Jenny Flynn, Dr. Fuldata, Dr. Hannett, and all those at IFP, thank you, not only for this opportunity, but thank you guys for your leadership. I also want to thank Dr. Stephen Rothschild and those at the Rush Family Medicine residency program that I came through, for them even instilling in us the desire to be leaders, even as residents, and sometimes seeing things in us that we didn't necessarily see in ourselves. And also want to congratulate all of the award recipients for IAFP that were presented this week, but especially my friend, colleague, and mentee, Dr. Carl Lambert. When Dr. Lambert was a student at Rush, I had an opportunity to be a mentor to him and just throughout his career. And I want to let him know how proud I am of him and the work that he's done. So I salute all of you guys. And with that, go ahead and proceed on talking about advocacy. So I'm currently the president of an organization called CHAMPS Alumni Development that's creating health and medical pathways for scholars. And we are basically the offshoot of the Chicago Area Health and Medical Careers Program that was based out of IIT since 1978. And this program has helped hundreds of physicians and healthcare leaders of color to go to medical schools, go to professional schools, public health schools, nursing schools, dental schools, and to become clinicians, scientists, and leaders in their communities. And for that, I'm truly grateful and honored to even be taking up that mantle to continue this advocacy for others. So I'd like to just quote a few numbers for you guys. According to the Association of American Medical Colleges, African Americans currently make up 7% of the overall medical school enrollment, despite being almost 15% of the United States population per the 2019 US Census data. Enrollment of Black students in medical schools has only increased 1.2% over the past 40 years, according to the AAMC. And of that, African American men make up about 3.4% of the medical student enrollment, which has declined over the past 35 years. So the consensus from the AAMC, as well as other organizations like the National Medical Association, which is the largest African American medical association in the United States, of which I'm a part of, that programs are needed, and as well as advocacy is needed to increase the numbers of African Americans and people of color in healthcare professions, especially in medicine. One of those programs is a program called the Pre-Matriculation Program at Rosalind Franklin University. Now, this particular program I'm very familiar with because I actually participated in this program. And this program has produced dozens of African American, Latino, and physicians of color who are currently in practice and working in communities all over the United States, not only as practicing physicians, but as leaders in their various communities and working with various organizations like myself. This pre-matriculation program has been around for decades and has a proven track record of success. And I want to commend my colleague, Dr. Fred Richardson, who ran this program for 7 years. But part of the reason why I'm speaking on this panel is because earlier this year, Dr. Richardson resigned from the program in protest. There were 6 of his students who participated successfully in this program and completed the required coursework for them to be able to be admitted into Rosalind Franklin University, only to have the door closed in their faces. These students have not only demonstrated aptitude in the medical school setting, but are leaders in their own rights, working with various organizations as mentors and leaders, and I'm proud of each of them. So I want to continue to advocate for them, but go into a little bit more detail about the entire situation. So after the resignation of Dr. Richardson in protest and the denial of admission for these 6 students, there were several protests that were held at Rosalind Franklin University. One of the photos that you see on the screen is of one of the most recent protests that took place on September 21st. And this was actually covered by the Chicago Tribune. We also had protests on September 7th and June 16th. And the Chicago Tribune, as well as some other media outlets, were there to cover what happened. Now, when we in CHAMPS Alumni Development found out what happened with these students, we were appalled at what happened, but we had gone through this previously and worked with the university's previous administration to rectify the situation. And previously, not only were those students admitted, but we sat down with the leadership at Rosalind Franklin University at that time and were able to come up with an articulation agreement for which, they agreed that this would be fair and equitable to all the parties involved. Well, fast forward a few years later to this particular year, and these 6 students who did well in those courses were recommended by Dr. Richardson and demonstrated aptitude as leaders in their various communities, were denied acceptance and were given various excuses. Some of them were told they didn't do well on interviews, although they did have to interview to get into the pre-matriculation program. One of the students was told he didn't do well on the Casper test. And when we initially reached out to meet with the leadership at Rosalind Franklin University, they were reluctant to meet with us and then finally relented after the initial article in the Chicago Tribune was published. We briefly met with the dean, the current dean, Dr. Chatterjee, as well as Rebecca Durkin, who is one of the leaders for diversity at the university, only to be told that these students would not be accepted, citing LCME guidelines, which the citing of that was incorrect and not even appropriate, but also citing the articulation agreement, of which we were at the table when this was formed, and expressed to them that the articulation agreement was not only being taken out of context, but at the time, the Casper test was not even available. So to quote the articulation agreement and to deny admission for one of the students and say that it was their Casper test when there was not a Casper test at the time that was written was a fallacy in and of itself. But beyond that, we continue to advocate for these 6 students moving forward. And in doing so, in shining a light on the current university's practices and shining a light on people like Dr. Richardson, who have been leaders with this particular program and leaders at the university and well respected by the students who've come through this program, well respected by his colleagues, and who have demonstrated an aptitude and excellence in educating these students and preparing them for careers in medicine, only to have the university not listen to him. It's appalling to say the least, but this is all the more reason why advocacy efforts like ours are needed. We currently have a petition circulating on change.org with the hashtag #AdmitThe6. And if Vince, if you can show that final picture where people can get a chance to see that. But the thing is these advocacy efforts are needed because even after 40 years, there's only been a 1.2 increase in the number of African-American medical students. We see the need for pipeline programs like these, and to see students who've successfully come through these programs only to have the doors closed in their face highlights the reason why programs like these are needed all the more, why we need advocacy groups like CHAMPS Alumni Development and others to stand in the gap for students of color who are not being given the opportunity, even when they've demonstrated the excellence and the ability to achieve at this level. So I want to encourage those 6 students to continue fighting the good fight. We stand with you guys. I want to continue to encourage those working with me with CHAMPS Alumni Development, including Dr. Dennis Garrett, Dr. Kimberly Battle Miller, Dr. Monique Alfred Jones, Dr. Elliot Forte. My condolences to you and your family in the loss of your brother, and others who have stood with us, and to continue to ask others to stand with us. The Illinois Academy of Family Physicians, when I discussed the situation with them, were not only supportive, but many of them signed the petition that was circulated and basically continue to help us in this advocacy effort as we not only advocate on the local level, but advocate statewide and nationally on behalf of not only these students, but other students of color who may have been denied these opportunities to go forward and fulfill their dreams. So with that, I'd like to turn this over to Lloyd Seeley. He's a current medical student at Rosalind Franklin University and also has been active with us in our advocacy efforts. Lloyd?
Thank you, Dr. Rembert. Hello, everyone. Wow. Everything you said is true, and definitely living that life right now. As Dr. Rembert mentioned, being a member of the PMP program, I did do that program starting, so I'm just going to share a little bit of my reflection on that as far, and also a little bit about what what's going on with the current scene at Rosalind Franklin University. Well, it took me many rejections, people telling me that I should do something else. I should do something else, be, anything but the physician I knew that I was supposed to be. I did grad school before. I have an MPH. And I was even talked to by some of the faculty members who said, oh, you should do something else, forget about it. I did 2 post-bac programs prior to coming to Rosalind Franklin. I was actually on my way to class where I met a friend of mine on the train in Los Angeles who first told me about the PMP program. Meeting the CHAMP leadership team was a godsend. I had free coursework, free. Even though I was essentially homeless, because I basically uprooted myself from Southern California, drove 2,000 miles to come to Chicago. I was homeless for 5 months during that time, and I was thankful to have another chance to further myself. What I did notice was that some of my instructors at university made us feel like an afterthought, as my program was being viewed as some kind of handout to minorities. Professors at times did not even have our names on their class roster. Regardless of that, I completed the program a little later, as I did have to fly back and forth to New York City, where my dad was suffering from strokes, and my mom simply was unable to manage his care at the time. I was still thankful for the opportunity PMP gave me. In fact, I got my very first A on my first medical school exam as a result of that. I was very happy. My medical school class actually had 20 URMs. 18, in fact, were from PMP at the time. And they were entering classes 2022, of which I'm a current member. I remember speaking to AOA member, Dr. Richardson, who was the research director of PMP, who anticipated pushback from administration, in spite of the fact that all 20 URMs have made it through without incident to the M3 school year. As anticipated, the pushback happened. Dr. Richardson was no longer able to have much of a say in the program that he was a director of. And as was mentioned by Dr. Rember, he resigned because of CMS's refusal to acknowledge their institutional agreement regarding the 6 PMP alumni. The current entering class of 2024 actually has 10 URMs of a class of nearly 200 students. My thoughts on what's going on regarding the 6, the denial is frankly disgusting. These 6 students have high character, empathy, they're academically high performing, and they have a lot of integrity. Despite their satisfactory academic performance in the program, 4 Black males and 2 members of the Latinx community were denied admission to the medical school. A similar event happened 5 years ago, where the medical school admissions committee denied 4 Black women and 1 Latinx member, only to reverse their decision. These 5 students went on to graduate from Rosalind Franklin, and they are now residents at Northwestern and Yale. I'm not gonna sit here and say that our school does not have good people, because they do. What I am saying is that there's a serious disconnect between what's being advertised by the school and the larger university and what's actually going on within our walls. Case in point, our previous medical school dean, Dr. Record, he advocated for students like me, but he was pushed out of the university because the university administration, simply put, didn't like change. His replacement, Dean Chatterjee, had a meeting with student leadership, mostly were white, and in that meeting, unknowns to her, they were actually allies for the URMs, and was saying, they literally told us that they needed a token student leader of color that would protect administration interests who would answer to her. To date, there are no full-time Black faculty in Chicago Medical School upper level leadership. And according to Dr. Vitale himself, there are not even 2 Black professionals on the medical school admissions committee. Now, in response to the bad press, our university has realized and admitted that actually All Lives Matter was actually tone deaf and insensitive response to the Black Lives Matter movement. 5 scholarships of $100,000 have been announced to incoming medical students. people of color. But my question is, what about increasing URM spots in the incoming class? Simply throwing money at the problem will not solve it. And what about the money for current and past PMP students like me? Where is that money when we needed it? While it is true that a PMP program was originally founded by CHAMP for Black students, they have also historically enrolled Latinx and other economically disadvantaged individuals would have included whites and Asians. The current leadership is so brazen to tell my Asian colleague that she wasn't entitled to PMP funds to help acquire study tools because she was not Black or Hispanic, even though she's a PMP alumni herself. That is just simply disgusting to me. She has to call me and tell me how in tears, how she felt that she just did not belong. No one should ever feel that way. And that's not what's CHAMP philosophy. Current CMS and student leadership need to tap URM leadership in the community and other URM alumni, consulting with them to how best address the needs of URMs. I am no longer proud of telling others about my school. As a healthcare professional, I am taught to do no harm. I cringe at the thought that every day URMs like me are being harmed under the guise of LCME. Currently, despite being actively bullied by those who do not agree with positive change, URMs and non-URM students are working together to bring a White Coats for Black Lives chapter here at CMS, as well as working with SNMA, LMSA, and CHAMP leadership as to how to make Rosalind Franklin University, particularly Chicago Medical School, accountable.
Thank you, Lloyd. Are you done? For sharing your story. That was really impactful. And thank you, Dr. Rembert, and both of you for just taking a stance at your institution. I know that's really hard, and highlighting ways that institutions may unintentionally discriminate against like Black and Brown physicians to be, and even while they're like in medical school. I think sometimes when we like affirm that Black Lives Matter, we often forget about like our colleagues and the bias that they may also endure, whether it's like on the way to med school, at medical school, or even as a physician. We can and we will do better. So now next we have Dr. Rothschild and Stephanie Moss from Rush University. They'll be talking about community engagement and their work around charge. So I'll turn it over to them.
Thank you. First off, I want to thank the other panelists. This has been really both inspiring, and it is something, you know, the work is hard, the work is long, but really have enormous respect for the push for equity in our medical schools, in our professions. So thank you very much for that. One of the joys of being older is to see so many of your students, you know, former students and residents in positions of making change, and not just our, you know, current student representatives like Laura Hurley and Stephanie Moss, who's who we're gonna be in dialogue with in a moment, but also Dr. Rembert, Dr. Fred Richardson, and Dr. Carl Lambert, and just watching careers thrive and feeling like, okay, I can retire now. You know, the world's in good hands with all of you. So thank you. Stephanie and I are going to talk about the work of Charge as one example of community engagement. And we're going to do this a little differently. We're going to kind of go back and forth in dialogue on this. We do have a few slides, mostly just as background illustrations. And they may or may not align with what we're talking about at the moment, but hopefully we'll flesh out some of the things we're talking about. CHARGE stands for the Chicago Homelessness and Health Response Group for Equity, and it began really on March 13th of this year. Rush, as many of you know, has had a long-standing community services program called RCSIP, that is led by currently Ms. Sharon Gates, soon to be Dr. Sharon Gates, because she just defended her dissertation. And that has been going on for the last 25, 26 years or so. And I have been part of it for that period. and it involves some clinical volunteer efforts by our students at Franciscan House of Mary and Joseph, a shelter on the west side where this story begins, but also community health, also Freedom Center, which is run by the Salvation Army, also a wide array of non-clinical programs providing support, literacy training for kids and other services. And as a result, we attract students who are interested and dedicated to community service. RICSIP, our community services program, is one of the strengths that Rush brings. But in March, we had a problem, which was that on about March 10th, Illinois crossed 100 cases of COVID positivity. And the university, like many of the schools, said, oh, we have to do something to keep our students safe. And so rotations were drastically restructured, and volunteer activities, including Franciscan, were put on hold. And students said, well, wait, we're there every Tuesday night. We're screening people, we're checking blood pressure, we're doing all of these things, we're refilling medications. How are we going to keep going? So within a couple of days, a group of us got together on a call. The executive director of Franciscan Shelter, 5 faculty members, 4 physicians, and a nurse practitioner preceptor, Sharon Gates, and Stephanie Moss, my co-presenter. And our questions were, how do we protect the population? They are sleeping 2 and 3 feet apart. There is no 6-foot distancing. They do not have masks today. We couldn't space the beds apart if we wanted to. Every square foot was in use. How do we continue to provide medical care? How do we make sure they have medications? What do we do if somebody gets sick? And we very quickly realized we did not have the answers. This group of 7 people was just, we were going to need a bigger boat, for those of you who remember Jaws. So we started making calls. And one of the advantages of a longitudinal project like RICSIP is you have a lot of friends and a lot of colleagues and a lot of people you worked with. So by the end of a week, we'd been having daily calls about this problem, including Saturday and Sunday. And we had 50 people on the calls representing city agencies, shelters around the city, other clinical entities, and a bunch of students. And today we're at 140 members. So I'm going to ask for the next slide, and I'm going to just ask Stephanie to talk about, her recollection as a student of those early days of Charge.
Great, thank you, Dr. Rothschild. Yeah, I just want to follow up that those definitely were very weird days for everyone. There was panic. I'm sure everyone remembers there was talk about toilet paper running out. Should we wear masks? Should we not wear masks? What should we do? Do we need to go run away? It was crazy. And so I think in this mix of panic, it was so meaningful to have something that I could do. And even though that was just calling in 8 a.m. to these phone calls to speak with these group of physicians, homeless shelters, leaders, real leaders that were actively doing things, coming together and brainstorming with the common goal of wanting to protect the individuals who do not have a home. And yeah, just like Dr. Rothschild said, it expanded so quickly. We started off by saying, okay, what are the things that we have to address right away? PPE was a big one. Up to this point, no one used masks. None of the shelters had gloves lying around. They're not medical centers. Thankfully, because we were connected with Rush and we had a lot of the supplies, we just, at the very beginning, I just ran into our RICSIP closet, and I just started grabbing all our gloves, all our masks, any cleaning supplies, anything we could think of. Dr. Gates also went into and got supplies that we do for when we go overseas and do global health initiatives, and we just grabbed everything and leaving one box of everything. That's one thing I do remember is I left one box of gloves, one box of masks, we said just in case, because we didn't know, no one knew. But that was kind of the start of trying to figure out what do these shelters need and what can we provide. So starting with PPE, then we went and talked about the getting people screenings, because at this point we knew a little bit about this virus. We knew that it was that it was airborne, but people had a fever. So we went around, we tried to find thermometers. Thermometers, if you guys remember, were really hard to come by. We were trying to order them from Amazon, try to find them at clinics. It was so hard to find thermometers. And we just, we finally, as we started going, we started to give each shelter one thermometer. And that's kind of where this went, of trying to figure out what the shelters needed and connecting them either with supplies, with volunteers, or individuals. So that's kind of how it started. And yeah, we will talk a little bit more. Dr. Rothschild can go next of talking about additional things that we did.
Yeah, I think, you know, I don't want to underestimate, you know, Stephanie is being fairly modest about this, because really the level of chaos or crisis facing shelters. Staff were panicked about their health and their family's health. People were calling in. We didn't know if there were going to be enough people to staff the shelters. So our students really stepped up. You know, they were the utility infielders, doing education on site, showing people how to use the PPE properly. We'll see some educational pieces in a moment. So and so on. And so as we try to get through these immediate tasks, we were deploying anybody and everybody we had to do this. And Rush's, I don't even know how the U of I students, if there was U of I faculty, I think may have reached out to U of I students, but it became this network. The Rush students also stepped up when we got a donation of 25,000 masks through Project Hope. They made sure with our partners at the Illinois Public Health Institute that there was a distribution system to every shelter in the city so that those masks would get out there. Go ahead and show me the next slide, Vince, please. So we have a few slides showing our students going out and doing screening. As you might expect, our medical school leadership was nervous. Wait, we don't want to put our students at risk. So you can see there was a high degree of use of PPE here. We did a lot of training on that. You can do the next slide, Vince. We really, you know, kept distance. So every day our team would go out into a Franciscan shelter. There was a similar team from U of I at Pacific Garden, constituting the two largest shelters in the city, and asking everybody their symptoms, taking their temperature, but also doing education, also reminding people why the masks were important, why the distancing was important. It was one-on-one interactions. Charge also then realized that, okay, so what do you do if someone is symptomatic? So we created mobile testing teams with the city. And again, our students weren't allowed to swab, but any shelter in the city where one person came up positive, we immediately moved the team in to swab everybody, staff and guests at the shelter, so that we could find out who was positive. And then anybody who was positive, the city created with Rush and Rush's College of Nursing a medical respite unit at a safe haven on the west side, because there's no place to isolate in a homeless shelter. So this created an opportunity for people to move to a place with 24-hour advanced practice nursing coverage for protection and to keep the spread down within the shelters. Simultaneously, we realized that some folks were going to get hit harder than others, especially the large population of homeless women and men over the age of 60 or those with chronic diseases. So Charge advocated with the city and the Department of Public Health to create a shield housing at a luxury hotel in Streeterville, a few blocks from Northwestern, so that each person at risk had their own room and they could have, food brought to them. There was a deck where they could go out and, catch some fresh air, but it allowed them to be safe while the pandemic was at its height in April, May, and June. We also went on working with our student teams and experts from Heartland Alliance Health and Lawndale Christian Health Centers, the two largest healthcare to the homeless providers in the city, to create standards of care, because we realize there are not standards of excellent care for the homeless. And I have to confess, when we did our work at Franciscan for many years, we did what we could. It was a Band-Aid on a major medical problem. And we probably felt better about it than we should have, because it was something, but it wasn't nearly enough. And so Charge is also forcing us to confront, what does excellent care look like and what should we be doing? And as a result, we've advocated and worked with the city, and the city has now created a funded system by which every shelter in the city will have coordinated primary care. Every homeless person, every person living with homelessness has access to primary care. That's just kicking off now under the leadership of Heartland Alliance Health and Lawndale Christian. But it's a huge enterprise. And all of this comes out of the work that our students and faculty and all of these organizations have done together. And one of the keys to this, again, has been the students. So, I want Stephanie to talk a little bit about the growth of Student Charge and the work that's going on now. And Vince, you could go ahead and, as Stephanie's talking, kind of flip through slides every, 20, 30 seconds.
Yes, thank you. It was interesting to be a student in this time, because we had to, as we started to take a step back from being on campus, a lot, just like Dr. Rothschild mentioned at the beginning, most of the students that come to Rush the reason they chose Rush is because of community service. Yes, we also want to become doctors, but we want to become physicians that truly understand and try to work with the community and serve them in every way we can. And I think that was so important during COVID, because all the students wanted to do something and they just didn't know how. And this created a really interesting ability for us to critically think and try to figure out, okay, well, we can't be in person. How can we still serve the needs of the individuals virtually? And that's kind of where we started. Is we started bringing together, we had, just as on the screen right now, we started with creating care packages, getting donations, financial and physical items from the community, and then creating care packages in this specific situation. We had one student come every single day to this location and build care packages. We did that every single day for months on end. That has created almost 2,000 care packages. Each of the care packages had very key things that individuals need in these shelters. For example, soap, toothpaste, lotion, snacks, socks is a big one. These minute things that if you haven't lived in this situation, you don't realize how meaningful and important it is. And one of the reasons why we did create care packages is we wanted to address the mental health and because all these individuals had usually without COVID, the shelters were only open during the night. With the advent of the 24-hour lockdown and quarantine, individuals now had to stay in these shelters without leaving, without going to their jobs if they had some, or going to the street to acquire supplies. So it was there was a lot of anxiety in the air for them of having to stay in these shelters 24/7, now having to wear masks. So the care packages also had the dimension of supporting with the mental health needs. And we are very lucky to be able to work with psychiatrists in charge group to talk to them about how to incorporate doing telehealth virtual psychiatric care, but then also provide all the different mental and physical health needs. Additionally, like Dr. Rothschild said, we also try to support in education, health education regarding the virus, about infection control. And a lot of this was done virtually. And this allowed students to be incorporated all over the country. Some individuals decided to go home. We also opened in their other states so they could support either through Zoom or through calling the shelters or calling people to donate things. There's so many different aspects. One of the big things about this organization is it was all about collaboration. And there was never a hierarchy. Everyone, no matter who you are, as long as you care about helping people during this pandemic, they were welcome to the table. And I think that is so key. I myself am a Rush medical student. By no means was it just Rush. We opened it up to have, I had undergrad students volunteering with me. We had students, nursing students, PA students, any health professional, or like I said, anyone who's interested in homelessness from all over the country and all over Chicago. So I was very happy how this allowed us to have cross-institutional collaboration. Like Dr. Rothschild said, we started really collaborating a lot with the UIC health students because they were also a part of this charge group, and they also had their own screening procedures. So we collaborated a lot with them as they had created wonderful training documents, and we shared the documents between each other. It's been an amazing experience to be able to be leaders while also supporting in any way we can. I also want to talk about a little bit of moving forward, of what does charge look like moving forward for the students. Up to this point, there is we've tried to transition to have more of a leadership student structure and have leaders from all the institutions. So right now we're working on having about 4 leaders from Northwestern, from Loyola, from Rush, from UIC, to really create more of a strategy to help in the best possible. We've been as new leaders have from the M1 class and from the new students, they've been bringing up new ideas and initiatives. I don't know if it's on there. No, it's fine. One of the most recent things that we're working on is going into the shelters, either virtually or in person, to do interviews with them to see how they're doing right now regarding infection control, if they have hand sanitizers everywhere. Are the beds 6 feet apart? There's a whole list of questions, and we'll use this to be able to kind of have an update on how all 77 shelters are doing in Chicago and provide them direct resources depending on what their most needs are.
I know we've gone a little bit over. I want to make one last point because I don't want us to leave this without understanding homelessness from an equity framework, which is our first principle. Homelessness disproportionately affects Black and Brown residents of the city. And the impact of COVID has been disproportionate on Black and Brown residents of the city. This is not a personal failing problem. This is not an issue of race as risk factors. This is the product of structural racism, policies about home ownership, policies about lending, policies about hiring, policies about education that have gone on for decades and even centuries. And so while this is one example of community partnership across multiple sectors to solve a problem, this is fundamentally equity work because we're trying to undo the work of the structures of racism that lead to health inequity. Thank you.
Thank you, Dr. Rothschild and Stephanie. I definitely echo that. It was like very evident within a few weeks, first weeks in the pandemic, that COVID is a social and structural issue. And I remember hearing like during a meeting with Chicago Department of Public Health, like in the spring, they said that there were actually no cases that were being transmitted in the homeless community. And I can see how charge played a really big part in that. So I'm really heartened to see the interprofessional and cross-institutional collaboration that y'all made in such a short amount of time. And yeah, I'm excited to hear more in a Q&A. And just a reminder for all of our student participants on the call, if you want to drop some questions in the chat to either me or Laura, we can like go over them in the second half of it, this session, this town hall. So last but not least, we have Drs. Santina Wheat and Warren McGee from Northwestern. So they'll be touching base on policy and diversity and inclusion. Just how do we make our next generation of physicians more diverse and create an inclusive environment for them.
Thank you so much. And I'm going to give an advance apology. I just lost internet connection once, so hopefully that won't happen again while I'm speaking. And if I do, I will jump right back on. So I am the daughter of a really strong woman who was an educator who taught me that I was supposed to make sure that I was helping others, and who also really strongly believed that it was her job as a parent to make sure that the world was a better place for me, her child. So that is something that I have carried on from her. I think it's really my job to try to fight for everyone. And I really think it's my job to make my daughter's lives much better than the life that I have. And so one of the ways that I work on that is to quote Hamilton, to try to be in the room where it happens. And to try to really think about how can I help change policy? How can I make an impact there? I've been very fortunate in my medical career to have a lot of wonderful cheerleaders to tell me that I could do things and to help me get into spaces where I can actually have that happen. One of the great places that I've been able to do that is through my involvement with the AAFP on a national stage. So I am a member of the Commission of Continuing Professional Development. And one of the things that that has allowed me to do is to also serve on the subcommittee for health equity. And that's a cross-commission group. And we have representatives from all over the country, all different types of practice types. And what we get to do is we get to write policy and we get to write position statements on what our entire National Academy does and what they advocate for. And so I've been able to work on things such as how are family physicians supposed to be engaging in community health and how are we supposed to be advocating for our patients and each other. I've been able to, this past COD, which just happened earlier this week, we approved as a Congress a statement on race-based medicine. I was able to help write that statement and to say that as an academy that we need to recognize that race-based medicine should not be something that we're doing, that it's really racism. And it's amazing. It sort of flew under the radar that we did this thing, but for me, it has this huge impact on, okay, now the Academy has this statement, so we can go ahead and make policy change based on that, or we can advocate for things because we have this as our policy statement. So that's one thing that I've been able to do. In addition, I have raised my hand for a lot of things. So I also, as a program director, I am chairing the AFMRD. So I have to say the acronym like 10 times to do it. The American Family Medicine Residency Directors. We have a task force on diversity and health equity, and I get to chair that. And what we're doing right now is our accrediting body, the ACGME, is now asking all residency programs what they are doing about diversity, equity, inclusion, how they're making institutional change, and how they're making changes as far as their own program. And most programs don't know how to answer that question. They did a quick hitter question of all program directors back in April, and more than 50% of people said they had no idea how to answer that question. So what my committee right now is doing is creating a family medicine residency specific toolkit that you can use to assess and recruitment, your faculty development, your curriculum, the patients that you're serving, the institution that you're working with. And so we're hoping that by doing this on a national front, it'll be available to all program directors across the country, and they'll be able to take a look at their own programs and see where they are, because once you know where you are, you can see where your weak spots are and be able to make improvements. Everybody wants something to do, but they need to know where to start. And if we can give you a way to know where to start, then it's amazing. So that has been a lot of fun to work on. And then within my own program, as many things happen, I was in a car with my former program director and our former APD. We were driving back from one of the IAFP Spring into Action days where we were lobbying and talking about how we really believed in doing underserved medicine in our program. And everybody that came in really knew how important it was. But we also realized that not everybody knew their own personal biases. They didn't know how they were actually causing harm. And we had to look at ourselves. Even though that we were all there to do good, we wanted to make sure that everyone had a sense of where they were starting from and what their own internal biases were. And so we created a social justice curriculum for our program that we were actually able to do not only for the Erie program, but also the Lake Forest program. At the time, there were 2 Northwestern programs. We're now fortunate to have 3. And so we've been able to provide this training for everyone where we're looking at implicit biases and looking at the historical biases, particularly that are happening in Chicago and the surrounding areas, so that we can at least understand where we fit into the picture, where our system and the harms that we cause as a system are impacting our patients and each other, so that we can better interact with each other and our patients and know where they're coming from and know how to help. Because if you don't understand the root of the problem, then it's hard to make changes to move things forward. It's interesting because when I sit down and I talk to people about what I'm doing, I usually get this question of, well, how are you doing all of this? How are you making this happen? And Vince was saying at the very beginning when some of us are coming in that I'm an introvert. So this is not necessarily the thing that you would expect an introvert to be doing. But I actually, I'm not necessarily the person that can be out on a picket line. That is not where I thrive. But being in the room and being able to share my ideas on a one-on-one basis or in a smaller group of people where I know I have the content knowledge is something that I can do. And so I tend to raise my hand a lot. I'm really fortunate that I have family that supports me in doing that. My husband works on policy previously for the city of Chicago and now for an environmental organization. And we both feel like it's important. And so we're able to support each other in doing those things. And honestly, importantly, to have our girls see that we're doing those things so that we can show them that this is what you're supposed to do with your life and that we're trying to make their world a better place. So I do that on a daily basis. I feel like this brings me energy and passion despite the amount of time that it takes, because if I can make this world better for those of you who are med students that are going to come and practice medicine in the future, for all of those of us that are currently practicing, and my 5-year-old who says that maybe she's going to be a doctor one day, if medicine can be a better place for her, then it's something valuable. But Warren has been amazing in some of the things that he has done at Northwestern, and so I want him to be able to share a little bit of a institutional perspective in a different way.
Thank you, Dr. Wheat, and thank you for the organizers for inviting me to speak to you all today. And I have the privilege and challenge of being the last panel speaker before we get to the Q&A. Encourage the participants to put questions in the chat to echo that. And I think a few themes that came out today that connect with what I'm going to talk about are iterative improvements and collaboration. And for me, that we heard in the middle and with Dr. Wheat about initiatives that have been turned outward into the community, whether that's locally or nationally. And the initiatives that I've been part of have been turned inward and looking at the institution and what's happening there, and how to build relationships. So the first one I'll talk about is I'm a member of Feinberg's Task Force on Inclusion and Bias. This was inspired by an article that was published in 2016 from a group at Brown, where they reviewed the science lectures in the first and second year curriculum and found that almost every instance where race was mentioned in the lecture at some point focused on the biology, and there was no mention of the social construction. And so that really inspired that group there to take a close look at the science curriculum and see where they could improve and make changes. And that inspired a group at Columbia to set up their own guidelines for a curriculum that focused on inclusion and a bias-free experience, with a focus, for example, on when you look at dermatology, that almost all of the pictures you see are just light skin tones, and there's no discussion of what this would mean if it's somebody that had a darker skin tone, what's different, or what would be a challenge for recognizing common diseases, as well as what I mentioned before about race being only mentioned as a biological construct and not a social one. And so with those two initiatives happening elsewhere, our institution started a task force to do a very similar thing at Northwestern. And what we started with was to just include on the evaluations that students are given access to, a spot where they can mention if obviously if there was frank mistreatment, please talk to the curriculum committee about that. But also, was there something that made the learning experience not inclusive and bias-free? Was there something there that you felt worthy of mention? And that we set up a system where we could act on that and close the loop to see where we can make improvements. Secondly, all evaluators and all educators were given a module on implicit bias and on topics related to an inclusive and bias-free curriculum that they would have to complete before they could do any evaluation or to participate as a lecturer. And this year, we're taking that deep dive that Brown did into the curriculum to look at not just race and not just sex and gender, but all the different dimensions of diversity and social identity, to see where there could be improvements to be made in the content delivered to our students. So I will post in the link in the chat the link to our page, where you can learn more about the academic literature on this topic and the things that we're doing. For the folks watching at home on a recording, you can simply just search for Feinberg Task Force on Inclusion and Bias, and it probably will be the first hit. So I'm really excited for what we're doing here and happy to take questions on the specifics. But with that, I'll transition to the other initiative that I'm a part of. It's an organization called Sustained Dialogue. It was started by a negotiator by the name of Dr. Hal Sanders. He had worked with the US foreign policy group doing negotiations across the world for decades, and learned a lot about how to interact with people that have very different perspectives from you. And decided to turn that into a program to teach others about how to dialogue. And I think it's really helpful and important to bring up his definition of what is a dialogue. So I'll quote this verbatim from their website. Dialogue is a process of genuine interaction through which human beings listen to each other deeply enough to be changed by what they learn. Each makes a serious effort to take others' concerns into their own picture, even when disagreement persists. No participant gives up their identity, but each recognizes enough of the other's valid human claims so that they will act differently toward the other. And so I think that's a really powerful definition. And obviously it requires buy-in from everyone that participates. But it provides the framework for how the group functions. So we recruit students to participate in topics that touch on some very difficult topics to discuss. So this is whether it's religion, politics, sex and gender, or mental health. Students are invited to join a group where they can have a dialogue in this fashion on that topic. And the focus is, instead of just talking about the abstract systemic issues, we focus on experiences. What are people's lived experiences? And harking back to Dr. Blair's comment in her segment about learning from each other, learning from the diversity of people's lived experiences and their perspectives on things. That the hope is, through the discussion, we learn more from each other. And the model that Sustained Dialogue has is to eventually move from, okay, we learn about each other's experiences, we learn what issues are there on campus that are relating to this issue that we could address, and developing an action plan to actually address that. So just to give you one example, the mental health group in our first year realized that there were gaps in how our school dealt with the policy of taking mental health sick days, that we have a clear policy for people that have a set illness like COVID or influenza, but for folks struggling with mental health, how can we support those students? And so they formed a task force with our administration to articulate a policy that could give students mental health days when they need it. So I have other examples of specific things that came out of it, but we are the first professional school chapter of Sustained Dialogue. There's about 40 or so undergraduate chapters. And the institution is very excited about rolling this out with other medical schools that are interested. So that's what I have, and I'm looking forward to a great Q&A.
Thank you both, and for just kind of opening a dialogue, I would say, about anything from race-based medicine, policy around curricular changes that are more like anti-racist, and increasing diversity in residency programs. So now I'm going to turn it over to Laura. She's going to moderate the Q&A session of this town hall. So again, if anyone has any questions, please put it in the chat. Otherwise, we have some pre-made questions that we thought of. But yeah, thank you everyone for speaking. It was super insightful.
Thank you, Tiffany. And again, thank you everyone. I think just hearing about all of your experiences and the passion that you bring to your work is very inspiring, and just so great to learn from so many different backgrounds and experiences. So as questions come in, like Tiffany said, we have a few that we thought of, and a lot of them touch on things you mentioned. So I'm glad to dive a little bit more deeper into them. So the first question is, what are some existing barriers in teaching structural racism and its impact on health and medical school? And what are some creative strategies that can be taken to approach this? And so the way we'll do Q&A, I should have said this beforehand, but the way we'll do Q&A, it's open for all panelists. Not, there may be some questions that are specific, and those will direct to the specific panelist, but anyone can feel free to unmute themselves at any time and go ahead when you have an answer. So again, the question is about existing barriers on talking about the impact of structural racism on health in med ed.
Thanks, Laura. That's a great question. First, you have to be willing to admit that there is structural racism, because there are still people who, and organizations that don't want to admit that structural racism is in place and that the current system has been to the benefit of some while to the detriment of others. Once that conversation is able to take place on identifying structural racism, we need to identify the organizations, the systems that are in place to be able to start to tear down and deconstruct those structures and those organizations and put others in place. As I mentioned, with the AMC, there's been little progress in terms of the number of African Americans in medical school. Well, programs like the one I mentioned with the pre-matriculation program and CHAMPS Alumni Development and other programs around the United States are helping to address those situations, but we still have others who state that these programs aren't needed. that, you know, these are affirmative action and these are handouts, as Lloyd mentioned previously. And it's addressing that mindset because, you know, for every forum like this, there are forums that stand against the very thing that we're discussing this afternoon. So I want to applaud you, Laura. I want to applaud you, Tiffany. I want to applaud the IAFP and all those who are attending and who are shared today, because this discourse is one of the steps needed for us to be able to address the systemic racism that we're still facing to this day and we're seeing moving forward, even at the very heights of leadership in our country.
Well, I would encourage people to ask good questions and hard questions. When we heard from Dr. Weech talking about why are we continuing to have race-based norms on labs and things. When a professor or somebody says this is a 50-year-old Black woman, or or worse, we need to, we need to name and say, well, why is that piece of data relevant? Help me understand that. That's easier for faculty to do than for students, but we all can ask good questions about why are we doing this? What is learned? And challenging, whether it's on STEP, where the case studies continue to have significant biases, or in the classroom, or on rounds. But I begin by asking the hard questions. We talk a lot about safe spaces. We have to create brave spaces in which we can be courageous and to raise these questions and deal with the discomfort that older faculty, like me, might feel, but got a challenge.
I just might add that I really think the change of the STEP exam to pass fail might be an opportunity for curricular development in really good ways. Of course, there are going to be, there's lots of caveats to that, but I think, we really have fought that battle. We often are preaching to the choir with teaching structural racism. The people that come to those sessions or pay attention to that content are the ones who might already have a background or a good education in it. And that's, the ultimate goal of medical education is to get every one of those graduates fully informed. So I have that hope. I do think that there's some real open windows here to bring in content that's not traditionally thought of as medical education and intertwine it into those case studies that have all the pathophysiology.
I would just add, we really want to highlight what Dr. Rothschild said about the faculty that have been doing this for a while. I don't actually think it even matters if they're older faculty or not. We've all been taught a certain way, and we're now being asked to teach something that we didn't learn. We're being asked to undo all of our own learning, and so we're sort of learning at the same time while we're teaching it. And as a medical student, I felt like I always expected my faculty to have the answers. And so now I'm at the other side. I'm expected to have all the answers, but trying to deconstruct everything that I have been taught along the way while also teaching it to myself and teaching it to you, that is a big, big ask. And so all of us are stumbling along the way. And those of us that are wanting to engage in this work, it's wonderful and it's rewarding, but it's 100% not simple. And I also think that I've had the fortune of going through the implicit bias training that Warren mentioned because I teach small groups at Feinberg. And watching some of the questions that came through that, it was obviously in the midst of COVID for this academic year. Some of the questions that came through the chat, everybody's coming at this from a different space and a different level of understanding and trying to learn. This is a lot to deconstruct, and it's not someplace that we're going to get overnight, but I think that we all need to keep pushing and getting ourselves there.
One thing that I'll add is, I mean, with the exception of the anecdote we heard today, I think the vast majority of people that we interact with have good intentions, whether or not. So one of the concepts we actually talk about in sustained dialogue is the intent behind an action versus the impact of that action. And that oftentimes we can have people that have good intentions, but for whatever reason, the impact was terrible. So I mean, the slip of the tongue with a phrase that comes across as very offensive, that most of the time people are not intending to offend. And so I have found in my interactions with the administration and talking with peers that also are doing a lot of this curriculum development work, that when you come from a place of giving the other side, the folks that you might disagree with, the benefit of the doubt, and focusing on where's the common ground that we can work together to build forward, even if we disagree on some of the specifics, that can break down barriers to change.
I want to jump in. I want to say first, thank you, Warren, for mentioning that. It kind of goes off what I was just starting to think about, because I come from, I think it's also important to take the perspective of the individuals who are color and African American, as I am myself a Hispanic. But I'm saying this because sometimes it seems like there's an expectation also from institutions that individuals similar than me need more help, need more support. They need to be in a group with other like-minded, or I should like-colored people. And I think that it definitely shows the implicit racism a little bit. Yes, always they're trying to do the best, they're trying to support, but coming in and assuming that the student is different, assuming that this student, just because of the color of their skin, is going to need extra help to even make friends or even just get the same results, I think is kind of flawed, and actually unintentionally encourages a culture, oh my goodness, the word just slipped my mind. The belief of not feeling accepted, and not imposter syndrome. That's what I was thinking of. I think that is very prevalent already, and not just people of students of color, but all students. And so instead of focusing on and separating individuals who are color and talking about imposter syndrome, bring it to everyone. That this is something that everyone struggles with. Everyone struggles with mental health. Many students struggle with finances. And I think it's important that instead of just segregating to address issues that most likely that individual has had, address it with everyone, every student the same, because you don't know what that individual has been through. You don't know if there's a white or Asian individual that also has a family that's been through divorce or has been a homeless individual. You just don't know. And so I think it's so important for, as physicians, to treat everyone the same, in the way of not assuming that they need extra help, or assuming that they are less than or have struggled, because everyone has struggled. And so, yeah, that was my roundabout way to kind of try to explain my mind.
Can I jump in on that? One of the issues I found is that, especially with medical education, there seems to be a disconnect between that and public health. It's very, very interesting when I talk to physicians, I talk to healthcare professionals, and they literally look at public health as trash, when literally public health literally drives the community. I mean, we're thinking about COVID, that's a public health issue. CDC, that's public health. Sanitation, that's public health. Food insecurity, that's public health. I believe what Stephanie was mentioning, like we need to look at people as individuals and also look at the communities where these individuals come from and pay attention to those issues. For example, like my friend that I mentioned, she had financial issues. Part of the reason why she was in PMP because she had disadvantages. But you want to just look at her, just assume that she's Asian and say, oh, she doesn't need any support, but she needed this support. And that's why she was in the PMP program. But there are people who unfortunately judge by, the amount of melanin in your skin, features and whatnot. But I honestly believe that medical education needs to be more in harmony with public health. And that's like the biggest thing that I can say regarding just medical curriculum, because in fact, I believe there are some countries that you don't even get to study public health until you have that medical background. So that's kind of telling.
I want to underscore something Lloyd just said that is so important, which is the skill that in theory we train in medical school, and in reality, I think we train out of people, which is asking questions and listening to answers. Because everybody on this call, you're all super smart, and you've gotten through all these hurdles. And so whether you're students or faculty or whatever, we feel like we've got the answer. I can help. I'm here to help. Just let me help. And it's so important to begin by listening, whether you're, working one-on-one with a patient with, tell me your story. How did you get here? What are the circumstances of your life? What are the things that have gotten in your way? What makes it hard for you to adhere to the medication that, that was prescribed, or got the tests that were ordered? Or at the community level, what do you all see? So begin by listening first, and understanding, and especially if you're not of the community you're trying to work with, just begin with understanding their experience, because it is so much richer, and your ability to help will be so much greater if you're there to partner and walk along with, and not to parachute in as the expert.
I'd just like to add a few things. I think everyone made such valid points. I think the school really focuses on equality and can forget about equity, especially with students who are struggling with so many different things, or maybe not struggling, but that they have a disadvantage to the same resources. For instance, when we have a talk about financial aid, everyone assumes that all of the students can obtain federal resources, but someone who has DACA status can only apply for private loans. Speaking from personal experience, I have DACA status. So these kinds of seminars are not useful for me, let alone the other students who have the same identity. So we're focusing on the majority, but forgetting the few students who can't obtain the same resources. And similar to applying to residencies, do we all have a fair chance to applying to these residencies? Yes, we got into medical school, but beyond that, we're also more than just students. We have other lives. We have, politics dictating our lives too. So I think that the school should do a better job to pay attention to, the equity of resources and mental health as well. Is our staff, does our staff represent all of our students, not just the majority? And then just going on with the curriculum, we are focused a lot on learning about diseases, but I'd like to see more about what do all these various diseases look on different skin tones, right? I'm being trained to become a physician, again, for the majority. But I want to work in an environment, you know, that is underserved, and that's not going to look like the majority of people. So again, a large focus on equity and not just equality.
Well, thank you, panelists, for sharing your thoughts. I think there were so many powerful points brought up. I think, as many of you said, just the key takeaways, the brave act, I love that word, Dr. Rothschild, the brave act of engaging in the dialogue with active listening is not only the foundation of the relationship, but then you learn so much more about an individual's life. And as Lloyd mentioned, so many of these other factors about an individual actually impact health outside of the clinic. And I may be biased, but what better space to start some of these conversations than in family medicine? And as Dr. Wheat said, the brave act of committing to this long and complex work that it requires persistent dedication at any age and at any training level. But this is a great place to start. So we did have a couple of questions come through the chat. So specifically on curriculum, one of the students on the call is on a working group related to her school's curriculum. And the question is, what are some issues that have come up in any of your efforts to implement curricular changes, and how did you handle them in productive and or constructive ways?
I can get the ball rolling. I mentioned that I'm on a curriculum task force and have been with the group since its inception 2.5 years ago. And I think Dr. Wheat mentioned one of the major challenges, which is that both on the faculty side, so the folks in charge of each unit, as well as the individual lecturers, but also on the student side, that everyone has immense demands on their time and they're being pulled in 20 different directions. So the immense challenge is, how do we add in one more thing to the curriculum when in reality, it requires a perspective shift that this is something to think about for the whole curriculum. So a few of the things that we've done to help address that challenge. So one is thinking about very small things to small changes. So I mentioned before that we add that just one additional box on evaluation forms for students, and that one module for faculty evaluators and lecturers. And then as we're going through the curriculum, we have a large team of students, faculty, and residents that are going to be helping to review all of the curriculum content. And this leads into the second point, which is try to find the influencers and the folks that can implement change. So this is talking with residency program directors, talking with department chairs, talking with the folks in charge of individual units within the curriculum, because if you can get buy-in from them, the change will flow from the leadership. So I'm grateful that our group has been able to talk with all of the different clerkship directors and residency program directors, and we're expanding these efforts beyond the first and second year to look at not only the third and fourth year, but also the resident level education. So hopefully that's helpful, but those are kind of the two big takeaways. So think small and try to find the influencers and get buy-in.
I would give two practical things that are challenging are time and money. Whose time is going to do this and who's going to pay for it? Fortunately, I think there is a lot of money to be found on this right now. There are organizations that are willing to provide grants to help sustain some of this. The program that we did for my sister residency programs was through a grant in Northwestern. I sort of get annoyed with this, but it's kind of like the hot topic right now. And so people are excited about it. It's like the cool thing to do. And I worry about that though, because I worry that that means that everything is going to be sort of superficial. And I want to make sure that we're all doing this work so that we really get deep into it and are really doing it for the right reasons. But so making sure that your organization is willing to buy out somebody's time to truly work on this. And if you can bring in people that really know what they're doing to help get you started, if you don't have an expert in your organization, it's helpful as well. And to be able to buy their time to do that is worth it and valuable and important to the movement, in my opinion.
I completely agree with the time and money piece. I'm going to offer two more. Each of us have done two, so I'll do two. Representation and new pedagogies. So representation, I mean, you know, the Central Curricular Committee has to have representation on it. So whether that's from someone from your Office of Diversity, Equity, and Inclusion, or that the membership of that committee is specifically addresses making sure that there are people from various affinity groups on the committee to help give the input at the top. So I think that representation is key. And then by new pedagogies, I mean, I think it's so true. This is not a medical curriculum cannot add, right? It's almost a one in, one out situation that's so packed. So we have to think of new ways to overlap the teaching of pathophysiology with structural racism, with social determinants of health. I think if we don't, we run the risk of all of anti-racism and social determinants being othered, kind of like the soft skills already are. You know, the history skills or behavioral sciences are kind of othered. And so we don't want that to happen with this key content. So I think we need to design our sessions in a new way.
I want to take advantage of my really brilliant colleagues and to ask a question about this, because I don't have one on the curriculum, but I think that to some extent, if we're honest about this, any curriculum, any training ought to make some either other faculty members or students, especially white students, uncomfortable, right? I mean, I don't think we have talked about privilege in the last, in this conversation a lot. We've talked about the lack of it, but implicit in that is the fact that some folks have privilege. And it feels sometimes like we have to dance around that. And I struggle with that as an educator, what that space is, Dr. Blair, what that curriculum looks like, how hard to push, how hard to lean into the discomfort, knowing that some folks are going to get up and walk out or go, complain to the curriculum dean that's, that this is a, anti-white racist curriculum. So how do we thread the needle? And, for those of you who have been working in this.
I may say that the answer is just to keep focusing on the patients. I also think mostly what we're talking about is the preclinical curriculum a little bit in what we're talking about here, but every student, privileged or not, will get to the clinical, their clinical years and see what we're talking about in live form. So I don't know if that means early clinical integration or, just picking the conversation back up again in the clinical years. But I think I do hear you that, it's a lightning bolt of a conversation if it doesn't have context. But I think the clinical spaces we're in is enough context that no one can really argue with.
I guess I feel like we break down walls. I don't know. I'm not necessarily a I'm going to blow everything up person, but I do actually feel like this is one of those things that I want to blow everything up. I think Warren said something really important, was that you have to get the influencers. So you have to get the person that's in charge to buy into this, to know that you're ready to break down the walls. And I think that one of the things that I saw happen sort of on the outside of the medical school, of getting to watch some of the benefits of this, is that I think that I watched some of the leaders really back people who hadn't been heard before. I think that they were able to back some BIPOC faculty that were able to make statements that hadn't been able to do that before. They were able to back, we do a book club for entering M1s, and they tried, they were not completely successful, but they recruited a whole lot more BIPOC faculty so that there was always at least some representation and some mentorship that was available. And it's been intriguing to watch it change over time. But I don't think that that would have happened had there not been buy-in from on top. I don't think that up top yet is as diverse as I would like it to be, but I at least think that seeing some of that change and that constant pressure has been helpful. And honestly, to all of the medical students here, like what I hear always is that it came from the medical students. Like it didn't start with the faculty. It came from the medical students saying, we have a problem with this. And I'm not gonna lie, when I joined Northwestern's faculty, I was kind of surprised and didn't expect that to be my people. And I've watched it change over time here to be a place that is doing the things that I wanted to do, but it came from the students and their interests.
I can add to that too. Dr. Richardson actually had, while he was a director and even before that at other institutions, he actually had Saturday afternoon sessions with students. I mean, whether you're URM or not, anybody, whether what school you went to, whether you are a student, high school student, whatever, just come to the sessions. And he would literally work it all the way up from what you're studying in high school to what it and how it presents on the level of a patient in an acute setting or otherwise. So you have people who are put on the spot. You know, change is needed. You know, I don't know about you, but my brother had growing pains, okay? And growth is not meant to be a nice, great process. You know, change is uncomfortable. You know, I don't know about anyone here. It was uncomfortable becoming a medical student. It was uncomfortable getting through the different levels of education. So, you know, if you're uncomfortable, that's probably a good thing, because you know what, you're probably going to remember it. You're probably going to learn it. You know, even memory is tied into emotional, cues. You know, so let's not run away from that. Let's go towards that, because you know what, it's going to be harder for the next generation because we keep passing the buck. The buck has been passed all the time. And I think now you're starting to get this, okay, we're kind of tired of the stories or the excuses we have heard previously in previous generations. You know, we got to start. And I think for professionals, just having that discussion amongst yourselves. You don't necessarily have to directly engage students all the time, but just bringing that point, bringing someone aside and saying, hey, Dr. Such and Such, hey, Mark, hey, Betty, you know what? I was kind of listening to some of the feedback from some of the students, and, you know, maybe you could consider putting it this way. Oh, you know, no. And being more open to that kind of constructive criticism. You know, medical students are always told to accept constructive criticism with a big smile. But I've noticed that faculty members kind of really run away from that, or even put up a wall when even amongst each other, they're trying to encourage each other to be better people. So.
Awesome. Dr. Rothschild, that was well put. And I want to second what Dr. Wheat and Dr. Blair said. We definitely need to be in the room where it happens. We need to have representation where not only the curricula is being decided upon, but have people of color and people of color who genuinely want to represent the communities that they come from, to bring that knowledge, that understanding, that compassion to the table, because that's where you're going to see the change take place. As Lloyd just mentioned, change is not easy. These systems have been in place, some for centuries. So to be able to overcome this, it's going to take time, it's going to take effort, but I'm encouraged by seeing our youth. I'm encouraged by seeing these medical students. As I mentioned, that family medicine leadership group at Rush, seeing many of those students who were leaders in their communities even before coming into medical school. So when they came to medical school, they had that mentality that I'm going to change the status quo even before they sat down for one class. And they carry that with them through medical school, through residency, and many of them now into practice. So having that mentality that we understand that these students are already leaders. And this was something that, was emphasized to us, not necessarily in medical school, but emphasized to myself and others when I was in residency. I remember Dr. Maria Brown, who is a fantastic family physician. She had done a medical missions trip to Tanzania and went with a group from ABC. And it was just phenomenal. And they ended up doing a documentary that won an Emmy. But she came back and told us, whether you guys realize it or not, you are leaders. And people are going to be looking to you for advice, for wisdom, and to potentially save their lives. And for not only the students who are in this forum, but to everyone, whether you guys realize it or not, you guys are leaders. You're going to touch the communities that you've been called to serve. You're going to touch people, whether you realize it or not. The choice is whether you choose to walk in that leadership and to carry that mantle and to be a change agent, or to continue with the status quo and we continue dealing with some of the same issues 10, 20, 30, or 40 years from now. So the choice is yours, but the choice is ours as well. At this point, we choose to make the difference. So thank you, guys. Appreciate your comments.
One thing that I'll add, and this is a call to the medical students. So depending on the specifics or the issues, when you meet with influencers, it can often feel like you're going into it with an adversarial perspective, that they are doing something you don't like and you're trying to get them to change their mind and do something different. And just going back to that sustained dialogue model of working from the mind of somebody who's a negotiator for decades and decades, that part of a successful negotiation is trying to understand where the other person is coming from and what are their interests, what do they care about. And a successful change can come about when you can successfully think about what is it that they care about and value, and how does that align with what you care about and value. And one important thing to keep in mind is that every medical school is accredited, and there's an accrediting body, the ACGME, and part of their accreditation requirements includes topics related to promoting a safe and inclusive learning environment for students. And medical students actually have a lot more power than I think most realize, where every graduating fourth-year medical student fills out a survey from this organization, and that accrediting body takes those survey responses incredibly seriously in evaluating whether or not a school will maintain its accreditation. So I guess I don't want to bring this up as like you need to use this as leverage, but realize that you have a lot more power than you realize in affecting change at your institution if you advocate for it.
Well, thank you everyone for sharing your thoughts and experiences. I don't think I have the words to top any of the rich discussion that we have had, so I'm not even going to try. I think everyone has posed some very thoughtful questions that will be good for all of us to reflect on and figure out how we will continue to act on those questions and act in action. So again, as we wrap up here, I want to thank all of the panelists for your time today and for guiding us with your experiences, as well as providing your feedback on several questions. Before we wrap up, we have just a few announcements and a couple of quick plugs for upcoming events. So Vince, if you want to flip through. So for students, for those aware, unaware, through the Illinois Academy of Family Physicians, there are a number of ways you can get involved. There's a health equity research webpage that Tiffany and I helped develop that is now live on the website. So we have the link here, and we'll be sending this. The slides will be available later, but if you also just go to the IFP website, you will be able to find it on there. Additionally, there's a health equity member interest group that is now up and running. It would be an opportunity to connect with other students, residents, and physicians throughout the state who are interested in continuing these conversations and continuing bravely in this work. And additionally, there's a health equity work group of the Public Health Committee, and Tiffany and I are both on that in that work group. And so if you have any questions specific to that, you can always reach out to one of us as well. And then I think there's And then I know Ginny put this in the chat, but just a quick plug for the upcoming Family Medicine Midwest Conference. It's going to be a really unique and fun format this year. So part of the content is going to be asynchronous, so you can complete that on your own time. And there's lots of great posters and sessions that individuals have prepared. And then Saturday will be live. And the Saturday live plenary will be featuring Dr. Orgain, who's actually the chair of the Health Equity Work Group. And her plenary session is titled Becoming America, Facing Truths While Uprooting Racism and Healthcare. And she's working really hard to make it not only unique to Illinois, but also regionally. So getting a lot of great examples of programs that are addressing this well. So I think it'll be a really great plenary session, very excited. Registration for the conference is currently open for students, and it is $50 for students to attend. Another plug for those students who are applying or thinking about applying into family medicine, several Midwestern family medicine residency programs will be at the conference, and you can have the opportunity to connect with some of their representatives there. And then finally, some events that we have coming in early 2021. We will be doing an implicit bias training workshop in March, and we will have more information coming soon. It will be posted on the IFP website, so you can just periodically check that. And then additionally, there will be a Rural Health Summit also in March. And there is information on the IFP website on that currently. So if you're interested in learning more about either of those, descriptions are available with more specific information currently available on the Rural Health Summit. And with that, I will pass it over to Tiffany to wrap us up.
So thank you guys for coming. I am so excited to have y'all feature family medicine colleagues. If you're not doing family, I'm so excited to have you guys as a colleague. So thank you for coming. We actually have a survey for the student attendees to fill out. Laura is gonna drop it in the chat. And again, thank you for spending Saturday afternoon with us. And we would love to hear any thoughts, ideas, or feedback. Our MIG is super new, so we're hoping to get some ideas of what students want to learn about in terms of racism and or health equity. So feel free to email either of us or both of us with any ideas or questions or feedback. So thank you. Have a good rest of your weekend.
Take care, everyone.
Thanks everyone for participating. I'm here with tears of joy as for a wonderful afternoon. You've given me hope for generations way beyond me. Thank you so much.